Hi, everybody. This is Dr. Aravind. I'm a diabetologist practicing in Bangalore for the last 32 years, also the president of Diabetes India. Welcome to another episode of Roadinar, and we'll be discussing something very interesting and what is really bothering the doctors. Now, it's diabetes and heart failure. And I want to tell you, I'll be meeting Dr. Girish Navasundi very shortly. So, we are going to be bringing a lot of information about diabetes and heart failure and the problems associated with it. Are you guys excited? Come along with me. I will take you now. We are meeting Dr. Girish. So we are here at the Sheraton Lounge, and I did promise you that I'll be making you meet a very important person. Meet Dr. Girish
Pleasure's
Navasundi.
mine, sir.
It's a lovely surname, Girish. Where did you get this surname from?
Yes, I'm basically from north of Karnataka.
Huh.
Navasundi is actually a designation in Nizam's rule. It is a district collector.
Okay.
So that my grandfather was into revenue department of Nizam. So it's got carried away. And
Is
so
that the
is
reason you also took up cardiology, the revenue wise? No, I think jokes apart,
yes,
Girish has been a wonderful cardiologist, interventional cardiologist for the last 2 decades. He's practicing and heading the Apollo group of hospitals. He travels among the Apollo hospitals in Bangalore. Great experience in teaching and patient education. Excited to have you. I think I'll shake
my
hands
pleasure.
now officially to you. Okay.
Thank you, sir. It's
Uh, Girish, I think we have a job to do today.
very true.
As a diabetologist practicing for now almost 32 years, we are seeing a huge rise in heart failure and diabetes. You know, if you look at the data from the IDF versions, it says that almost 20% of the people with diabetes have heart failure,
True.
and it's about 4 times more compared to a non diabetic. It doesn't end
Absolutely.
there. Recently, I was looking into the data of this Trivandrum registry done by all the cardiologists. It says almost 45 to 50% of the people who are in the registry who are getting admitted for heart failure actually have diabetes.
Diabetes.
So I think there seems to be a great increase. We are seeing a huge mortality, especially with diabetes and heart failure. The 3 year survival, people say, is about 40 to 50%. So a lot of people are dying. I think this is an important thing because almost 7, 8 years back, we never spoke of heart failure and diabetes. We are talking about coronary artery disease, MI, and other things. So I'm going to be asking you all the questions as a cardiologist, and I hope and request you actually that you would be giving wonderful answers to all the people who are going to be watching this episode of the Roadinar. Is that okay? Can we just take a
Perfect.
walk?
Perfect, Dr. Arvind. I mean, you've been a legend of diabetes. You've been managing diabetes for so long, but now the community is waking up to the fact that most patients with diabetes will eventually have cardiovascular related complications, and that will be the primary cause for end of life in them. More than 50% will eventually die because of cardiovascular disease. More so, the attention of diabetes related cardiovascular disease is shifting towards heart failure.
Yeah.
Because there's been a great improvement in the management of atherosclerotic cardiovascular disease. But this concept and the realization that eventually it's heart failure which really brings down the quality of life, leads to repeated hospitalization and eventual death. I think there's a great deal to be discussed on this front, provided you offer me a good morning coffee first.
I thought you're going to start with a cup of coffee. It's wonderful. I think as Mysoreans, we
Yes.
love to have our coffee. Shall we start with a filter coffee at the Sheraton?
Excellent. I love it.
Girish, you got your coffee. You know, coffee in a style that all of us love. Okay. Now, I think over the coffee, I really want to ask you an important question. What's the prevalence of heart failure in India, both in diabetics and non-diabetics?
It's really kicking my brain and starts talking. The number one disease that would cause maximum economic stress and loss of quality of life, I think in the coming days, is going to be heart failure. When you speak about prevalence, I think about 20% of the diabetics are going to have heart failure eventually. And among the heart failure, 50% are going to have diabetes. So when you look at the management, I think they become very, very crucial. Second, when you look at the hospitalization and death, it is worse than most cancers. When you look at the heart failure with reduced ejection fraction patients, the survival at the end of about 3 years is between 20 to 40%.
Oh, wow.
And those who have had more than 2 admissions for heart failure, by the end of 5 years, I think very few will be remaining if not managed appropriately.
And I was also told heart failure is occurring at an younger age group, their late 40s, early 50s, when you are in the prime of your youth, you're working. And will they be able to go back to work normally? I think these are many challenges, many questions, which I'm sure I'm going to be asking. And then you did mention about preserved ejection fraction, reduced ejection fraction. So I would like to really know what is causing the heart failure in a patient with diabetes and non-diabetic. I think you should finish
Finish
your
the
coffee
coffee and
now
then
and
we'll
then
take it.
start moving around. I think Sankey Tank area is going to be a lovely area to walk along and then discuss all the structural changes in the heart.
No, thank you. I love the place. That's place of my childhood. I lived in Vayalika also. That's
That
beautiful place.
that's a
Let's meet
beautiful
there.
place. Girish, are you in a mood with such a lovely background and an area? Are you in a mood to take some questions and answer?
I think this is one of the most healing environment one can be. This has been one of the best locations of Bangalore. The Sankey Lake is a beautiful, sheen of water and a lot of birds around. I love this place.
Okay, cat laps to Sankey Tank. How do you say this experience in a sentence?
It is like, cat lab is like jumping out of the plane,
Oh,
all adrenaline. And then when you land, sit on a meditation, I think this is the place.
thank you. I think with that, I will come to the most important question. We did discuss that there is an increase in heart failure, especially with people with diabetes. As a diabetologist, when they walk in, there are hardly any symptoms. And I was told that there are different types of heart failure. People talk about structural and functional changes happen in the heart. And can you explain this a little more clearly?
Thank you. I think it's a great question, sir. Uh, Diabetes is one of the major contributor for initiation and sustenance of heart failure. Why is it so? Diabetes is associated with chronic low-grade inflammation.
Are you talking about the cellular inflammation that we talk of?
Yes,
Yes.
I think it happens at multi-layered. That is, there is endothelial dysfunction, primarily in diabetes. That leads to accelerated atherosclerosis, so premature coronary artery disease and diffuse coronary artery disease. So eventually it will lead to ischemia, myocardial infarctions, and LV dysfunction and heart failure. That's one component of heart failure, which is heart failure and reduced ejection fraction. Then you have 1/3 of the patients whose ejection fractions are normal on echocardiogram. And most physicians tend to think a person with a normal ejection fraction cannot have heart failure.
That's right.
But unfortunately, 33% of the patients with heart failure are going to have normal ejection fraction, but they have what we call heart failure with preserved ejection fraction. That means diastolic heart failure, this component.
I know. I think it's almost a decade since this concept came, and now it's quite clear that whenever we saw a eco report and which said that ejection fraction is 60%, we said, oh, your heart is absolutely okay. So you are saying that it's not so. Almost 1/3 have heart failure despite having a normal ejection fraction. Now, when we see an echo report as a physician diabetologist, we look at this left ventricular diastolic dysfunction. Now, how do I have to read this?
Absolutely. I think, you know, today's management of diabetic patient is not just about managing the blood sugars. It's about organ protection. We need to prevent atherosclerotic cardiovascular disease, heart failure, renal failure, retinopathy and nephropathy. So as a physician, we constantly look at these organs. So coming to the heart, I think periodical evaluation of heart function through symptomatology, physical examination, doing an ECG, echocardiogram, stress test, and need be a CT coronary angiogram are very, very crucial to prevent the acceleration of heart failure or atherosclerotic coronary artery disease. Coming to the echocardiogram, I think you need to collaborate with a cardiologist at least annual basis to look at the diastolic dysfunction that exists in this person. Is it associated with heart failure, or is it just the risk factor at this point but not causing heart failure at this point of time? Just to elaborate one more minute, heart failure has got functional class and staging.
Okay.
So staging means we call them heart failure stage A, stage B, stage C, stage D. What do you mean by this? Stage A means people who have risk factors to develop heart failure, but there is no structural abnormality yet,
Okay.
and there are no symptoms yet. Means those who have diabetes, hypertension, or have multiple coronary artery disease, but ejection fraction is normal, no diastolic dysfunction, no systolic dysfunction. These are categorized as stage A. They will develop down the line, so start working on their risk factors very aggressively. Weight reduction, good diabetes control, hypertension control, lipid control, etc. Then comes stage B, where they have a structural abnormality, but patients do not have symptoms, such as somebody who's got hypertension with left ventricular hypertrophy,
Okay.
somebody who's had a myocardial infarction, but fairly preserved ejection fraction, maybe 45 to 50, but he's able to jog, climbs 4 flights of stairs, he feels no symptoms. And those who have valvular heart disease, mild mitral stenosis, mild aortic stenosis, which is not limiting their physical activity. So these people have structural abnormality, but no symptoms yet. These are categorized into stage B. Stage C are those who have the structural abnormality, but they have symptoms. They are not able to do everything that his own, compatriot can do.
Can I just stop you there? I think that's a very important, valid point that you made. Stage A and B, majority do not have symptoms. They are walking around, they are jumping around. They think that they are completely normal. Now, to me as a physician diabetologist, is it not important that we pick them up at stage A and B? What are the tests that I can do to actually make a diagnosis of heart failure early? Are there any tests?
Great. I think this is the crux of today's discussion, honestly speaking, to discuss with our colleagues. It is the anticipation, or it is the prevention aspect is first. Second one is detecting the stage A and stage B of heart failure. How do we suspect? Now that we know, we have a patient sitting in front of us, slightly obese, diabetic, hypertensive. We know he is going to develop heart failure. So what do I do as a physician? First, ask for symptoms. To categorize into class stage A or B, there are no symptoms. But most these people claim they don't have symptoms, but then when you proactively ask, they say, you ask them, how's your fitness compared to 2 years ago to now? Are you able to climb the stairs, 2-3 flights with same ease, or you feel more effort at doing the same level of activity? That is NYHA class 2 from NYHA class 1. Are you, when you do strenuous activity, is it as effortless as before? They say no, but they think maybe doctor because of aging or something.
Correct. They
But
always give an excuse that, I have a little edema, probably because of some thyroid problem.
absolutely
Maybe sugars are out of control, maybe I'm tired or too much of overwork. Okay, so this is the problem that we face.
true. These are the symptoms that we should ask: breathlessness, easy tiredness, swelling of feet, unexpected gain of weight for no reason in a very short period of time, and then having giddiness when they exert. These are the symptoms that we should elicit. And as a clinician, we must try and auscultate the heart to look for any left ventricular S4 or any murmurs, or when you palpate, has the heart dilated? And then look at the pedal edema or elevated JVP. They're all early indicators of imminent heart failure. And then hepatojugular reflex is a little more on a routine practice, but these we can do. And thirdly, what we can do is ask for a few basic tests like an X-ray. You see a cardiomegaly. Then you do an ECG. It shows, some STT changes, T inversions, ST depressions, or left ventricular hypertrophy pattern, what we call LVH pattern. Then we know that this person has some diabetes related cardiovascular affliction already, which is a marker of future heart failure. And then you please, I request everyone to get an echocardiogram. That is the fundamental test which will talk about the structural and functional abnormality that happens in the heart of a diabetic person. Like how you do a fundoscopy for a retina, how you do a urine protein creatinine, microalbuminuria. All we have to do is one echocardiogram. And lastly, when you look at the blood test, I think one test, gold standard, is called NT-proBNP. If you suspect that somebody is having unexplained shortness of breath, easy tiredness, or when they exert, they feel uncomfortable, it could either be because of atherosclerotic coronary stenosis, which may lead to myocardial infarction, or is it heart failure? So one test called NT-proBNP, which got a great specificity for a great sensitivity for heart failure. If somebody is breathless and you do NT-proBNP, if it is normal, then 95 to 98%, we know that it's not heart related.
It's not heart related. It's not heart failure at least.
Heart failure at least.
Yeah.
So great. It could be coronary artery disease, but definitely not heart failure.
What levels of NT-proBNP do you think is really significant? Now, as a physician, they say less than 200 is kind of normal, and each lab has their own normal ranges.
Correct.
Okay, now I have a patient with symptoms, probably with very mild symptoms, and the proBNP is elevated. Beyond what level do you think I should take it seriously?
I think when you suspect, clinical suspicion is crucial. When you suspect somebody and you get a test done, it varies depending on the health of the patient. If he has no chronic kidney disease and less than 75 years of age, normal value is less than 125 if you're doing NT-proBNP. Okay. If you're doing BNP, less than 100 is normal. Okay. Nowadays, we do mostly NT-proBNP because this NT-proBNP levels does not change when you intervene with the drugs that we will be discussing, like ARNI or anything like that. But BNP levels will change. Yes. So the best test to do is NT-proBNP, not BNP. And when you look at the values, less than 125 is normal. And if someone is 75 years or older or have associated problems like early CKD, it could be up to 450 is considered as normal. But anything more than 450 is considered to be abnormal, and if it exceeds 1500, you're very certain that this is heart failure.
I'm going to be asking a very tricky question now from the physician's point of view. Just look at this. You did say CKD and the proBNP values, it's always discussed. Somebody comes with a creatinine of 1.6, 1.7, 1.8 and also has anemia.
True.
How reliable can the proBNP be? Because this is discussed in the diabetes endocrine and the physicians group. Okay, now proBNP is known to alter in CKD patients. And what should I take as something which definitely indicates heart failure in that patient?
Very true. I think we know if he's a diabetic and if his creatinine is up, and then you have NT-proBNP also up, I mean, this is a person with diabetes related multi-organ affliction already. So we are going to label him as a heart failure. Depending on the echocardiogram, we'll categorize him into heart failure with preserved ejection fraction if the ejection fraction is more than 50%. If the ejection fraction is between 40% and 50%, this is called a new term called heart failure with mid-range.
Mid-range, MR,
Yeah,
yes.
MR, or what we call minimally reduced ejection fraction. Now, that's how mildly reduced ejection fraction it's called. And the worst category is if the ejection fraction is less than 40%. So these people fare very, very badly. These people who have what we call cardiorenal syndrome, so eventually they'll have dysfunction of heart and kidney together.
Both together.
And they go hand in hand. If one is affected, it eventually adversely affects the other one. So in these people, elevation of NT-proBNP indicates that their prognosis is worse. Okay. It only means that you please control the risk factors very aggressively. You bring down the blood pressure to close to 120. In a diabetic person, hypertension is more harmful than the blood sugars. Yes. So you need to really get the blood pressure to closer to 120, not 140, not even 130. Bring it down, especially if they have a CKD and heart failure. Try to keep around 120 as long as they don't have symptoms of postural hypertension or giddiness. And then get very not too tight, but as best diabetes control that we can get. Closer less than 7 or close to 7. And thirdly, look at his lipids and manage very well. And thirdly, little more intent in looking at coronary artery disease. Many of them will have significant coronary artery disease underlying. So maybe a CT angiography, if the creatinine permits, if not, a good stress test would help you to manage this patient. And now coming to the numbers of NT-proBNP in CKD, I think it will vary depending on the severity of heart failure and severity of CKD. With 1.9 of creatinine, anything more than 1,500 to 2,000, you should still take it as significant.
That's a great information that we got today. I think I just want to talk to the listeners and then tell them, see, diabetes is not just a sweet disease of the glucose. It's slowly turning out to be cardiometabolic, renal and vascular in approach. And we just heard Dr. Girish clearly telling us that it's not just the diabetes part of it, but it's the insulin resistance, hyperinsulinemia, how it has an impact on the heart, how there can be both structural and functional changes, and how we classify heart failure with low ejection fraction, normal ejection fraction, and the mid-range, a new term that you will be hearing soon. I think the important thing is the treatment part of it. Sometimes it becomes tricky because these patients come early to us as physicians. So we need to be ready and equipped with what to test and how to start off the treatment and when we do the referral. But all about the treatment a little later as we finish our walk. Thank you so much.
Fantastic.
Great to be back and then standing in front of this iconic building, Vidhan Soda in Bangalore. Go back to the younger days when you come actually run in front of these roads. It's so beautiful. Now, coming back to heart failure, I think we should discuss about the treatment options. In the last 7-8 years since we started using SGLT2 inhibitors in the field of diabetes, it has kind of changed the scene of heart failure. Now we saw the EMPIREG and so many other trials coming in and showing nearly 35% reduction in 3-point MACE, 4-point MACE, hospitalization due to heart failure and this kind of a thing. Now, as a cardiologist, I would like to ask you, we started using SGLT2 for diabetes without realizing it can have so many benefits. How do you look at SGLT2 as a cardiologist, and what are the treatment options that we have for heart failure today?
I think excellent question, sir. I think that is where the what do you call the comprehensive management of diabetes starts when it comes to heart.
Okay.
I think the diabetes managed initially was just glucocentric.
Yes.
You just had to get the blood sugars under control. Now we know that every oral anti-hyperglycemic drug need to give you a cardiovascular neutrality or at least protection, or nephrology, kidney. It should protect the kidney,
That's right.
protect the heart.
Yeah. What
We have
more
moved
can
on.
it do beyond reducing glucose? Is the question that we ask.
Absolutely.
Yes.
I think when it comes to that, the greatest revolution of the decade has been SGLT2 inhibitors.
Yes.
It's been a cardiometabolic drug. It not only manages diabetes, but also protects heart and kidney both. So it's been acting on three organs, not only pancreas related problem, but also retards the decrease of renal dysfunction and also protects the heart against heart failure and myocardial infarction. So I think today, when you look at a heart failure management, there are four foundational therapies, what we call a beta blocker, SGLT2 inhibitors, then you have an ARNI and mineralocorticoid receptor antagonist like spironolactone and eplerenone. I think on the management priority, I think you have two categories again, as I said, heart failure to reduced ejection fraction, whose ejection fraction is less than 40%. They are the most vulnerable group of people who have highest rate of repeated hospitalization and highest rate of sudden cardiac death and worsening pump failures. So these groups have to be managed very aggressively. You need to start all four foundational drugs as early as possible, probably within a span of 7 days to a month, and then optimize them to the maximum tolerable dose.
Yeah.
It is not enough to start, but then you need to up titrate them to the maximum tolerable dose. Only then that patient can be protected maximally by the current standard of science in terms of pharmacotherapy. So what we have is beta blocker, SGLT2 inhibitors, ARNI, and mineralocorticoid receptor antagonist.
Okay.
On them, the priority wise, I think beta blockers come first.
Yes.
Because they are associated with most rapid and maximum reduction in sudden cardiac death. So that's why we initiate a beta blocker. I think very next is SGLT2 inhibitors.
Okay.
You know, this is one drug so beautiful that you just give one fixed dose. You don't have to change the dose for rest of his life, and you don't have to up titrate, down titrate. It does not cause hyperkalemia, hypokalemia, or hypotensions. So safely can be given compared to an ARNI or an spironolactone or eplerenone.
Okay. So what I understand from you as a cardiologist is you still trust in SGLT2 ahead of RD, because initially a cardiologist started saying no. As a cardiologist, I would still start an RNI first, as long as the ejection fractions are taken care of and contraindications are looked into. But today I'm so happy you said an SGLT2 comes into the force for the first time. But what's the role of a diuretic now?
Excellent. I think there are two kinds of diuretic. One is a loop diuretic, like you have furosemide or you have torsemide. These are basically used to cause diuresis and natriuresis. When somebody is volume overloaded, they come with congestive cardiac failure or a pulmonary edema. I think that's when you need to decongest the system, take the extra fluid out of the system, but they do not decrease mortality. They only improve the symptom and improve the quality of life. So they become last. But in an acute heart failure, they are the priority. But once the patient becomes euvolemic, you need these foundational four therapies, and only when there is a fluid goes up or you need a sustained diuresis, then it becomes a fifth add-on drug, not the first line of drug.
Okay, I mean, this is interesting. See, as a physician diabetologist, there are a few things that comes into my mind. What parameters are you frequently checking to know whether, of course, we did speak about pro BNP levels and probably prognosis wise, values coming down. But apart from that, how important it is to check the electrolytes and how do you adjust the dosage?
No, excellent. I think one is initiating these four drugs. What are the goals of these medicines? I think when you start a beta blocker, you're looking at bringing down the heart rates to less than 70 but above 60. If the heart rates remain more than 70, there is increased risk of heart related admission, heart failure related admissions and sudden cardiac death. So you need to bring down. If with the maximum tolerated beta blocker, if the heart rates are still high, then we add ivabradine. Next, you start an SGLT2 inhibitor. So it's a great drug. Whether there is diabetes or no diabetes, SGLT2 inhibitors have proven to reduce 3-point MACE.
Yeah, and now even with reduced ejection fraction, you can use it. So you don't really
Preserved
have to
ejection fraction
preserved,
also,
reduced, and then
mid-range, all heart
it
failure.
has no untoward effect on the EGFR, and then you don't really have to worry. It's
No,
great drug.
actually it is beneficial in terms of EGFR. It actually retards the worsening of the kidney function.
That's right. Yes.
So it permits these good drugs like such as ARNI to be continued for much more longer because it's holding on to kidneys function. It maintains kidneys function for a longer time. So SGLT2 inhibitors are not only doing their own bit of great benefit, but they're also helping other molecules to be continued. Imagine if the EGFR quickly goes down to less than 15%, then you may withdraw ARNI, which again reduces morbidity mortality by about 25 to 35%. So that's the great benefit. And no other drugs in the management of heart failure, no drugs have shown improvement in terms of hospitalization for heart failure or death when it comes to heart failure with normal ejection fraction. SGLT2 inhibitors as the class are the only class of drugs. So it's a great boon for these patients who had nothing all these days except diuretic for symptomatic improvement.
I think nobody expected that an SGLT2 would do so much. And another important thing that I see is, the patients have already started on an ACE-ARB the moment you have a little microalbuminuria positive. But then when ARNI started, many times I do see other ACE-ARBs being continued. And we have learned that probably there is no need to continue that ACE-ARB because valsartan is already there in ARNI. And I think this is another message that I think you have to give it very clearly. How to take out an ACE-ARB when you actually introduce an ARNI because it anyway has valsartan and we don't
Absolutely.
have to use this.
No, the idea of RAS blockade, renin angiotensin aldosterone system, that gets hyper activated in a background of diabetes. So you need to suppress that RAS system by using either an ACE inhibitor or an ARB. But an ARNI has got an edge because apart from an ARB, you also have neprilysin inhibitor,
Yes.
which is an additional drug. It not only blocks RAS, but also it allows for the naturally produced BNP to function for longer duration. So, and it has been proven clearly that in a patient of heart failure, it's ideal to stop ACE inhibitor and switch over to an ARNI. And how do we do it? Once you stop an ACE inhibitor, for next 36 hours, you must not initiate ARNI.
Okay, you want to give a washout.
Absolutely. Otherwise, it's been, when you give both ACE inhibitor with ARNI, there is chance of, angioedema. Very few cases, but there's a probability. That's why you must always stop ACE inhibitor, wait for 36 hours, then ARNI. If you're switching back from ARNI to ACE inhibitor, it's again the same. Stop ARNI, wait for 36 hours, and then give ACE inhibitor because someone may not afford an ARNI and if they want to go back an ACE inhibitor, but remember this 36 hours window period. But for certainly, ARNIs are superior to ACE inhibitors.
Thank you. I think thanks for that update because this is a very important message that has to go to all our doctors. And Dr. Girish, you have been running a heart failure clinic. Very few interventional cardiologists actually spend time in a heart failure clinic. Now, people want to know what more do you do in a heart failure clinic that has not already been done?
Absolutely.
Okay, can you tell us about what exactly
Excellent.
happens?
I think, heart failure is such a rapidly progressive disease and people fall off the radar very quickly. I think it requires a little bit of passion, not only from cardiologists, I think community of physicians as such, because these are the most vulnerable patients for repeated hospitalizations and their quality of life can go down if they consume 1 or 2 liters of extra fluid or if they miss couple of diuretic or ACE inhibitor ERB or regular drugs. If they miss for 2-3 days, the condition worsens.
So it's a delicate balance that they have to
Very
maintain.
delicate.
Yeah.
Very delicate. So you need lot of passion in terms of educating them, hand holding them, like you've been doing excellently in diabetes, maybe a step further in heart failure. So you need to look at their weights. If they gain weight, that means fluid accumulation. So you need to tell them and not to take over the counter medicines such as, the NSAIDs quickly cause fluid retention or worsening of the kidney function. So we need to educate them about it. And then coming to the drug, you must all the time tell them the importance of compliance with the medicine. Please don't skip the medicine because you're feeling well. You miss for a week, then we are starting from a very low level again to bring back to the stage that they are. And secondly, we need to tell them that there are going to be times of hospitalization and discharges and rehospitalization. So the main goal of treatment in heart failure is to improve quality of life and prevent hospitalization and then prevention of death. I think the first two priorities important priority. Then comes once you have given the maximum tolerable dose of all foundational therapies, important to avoid precipitating factors for acute decompensated heart failure such as anemias. Most often they tend to have iron deficiency. So I think once in 6 months, in those with reduced ejection fraction, please do an iron profile.
Iron profile, and then you have a total dose iron available now.
Yeah, now parenteral iron.
Parenteral iron is
and
easy.
correction of that greatly improves quality of life because muscle requires iron for its function, not only for hemoglobin. And thirdly, you need to control the heart rate because the more heart works, faster it fails. So keeping the heart rate less than 70 is very crucial. So once we have initiated all these, we go back to what else can we do. As we said, about 30-40% of them, the underlying cause is either severe coronary artery disease or valvular heart disease. One of the overlooked, because as physicians, we are very adept at managing medicines, but then sometimes we fail to see how I can benefit the patient more. I think that is where detailed analysis of severe coronary artery disease through a stress test or an angiography is very, very important. If it is severe, then you would greatly benefit by a bypass surgery or a angioplasty. Currently, the level of surgical skills and interventional skills has really gone up. And we must realize that heart failure and coronary artery disease are like cancers. There is no one-time cure to these.
That's right.
We need to buy time and improve their quality of life for 5-10 years. Again, they will need another therapy. So we need to educate them about it. And today, we do a bypass without cutting the center of the chest with a minimally invasive 2.5-inch surgery. And we do angioplasty for 2 times bypass surgery people also. So technology, science is a great tool, powerful tool. We must make use of it. Lastly, when you reach a point where angioplasty, bypass, medicines can't do much, then we have cardiac transplant, and those who have NYHA class 2, means who are able to walk around, do everything, but have poor ejection fraction. They have a good quality of life, but they're at the highest risk of sudden cardiac death. Whenever somebody becomes unconscious with an arrhythmia, 80% of the time, it is ventricular tachycardia or fibrillation. It is not asystole. How much ever you do CPR,
it's not going to be normal.
Come back. You have to defibrillate. You need to shock. That is why implanting a defibrillator saves so many lives. Sudden death can be decreased to an extent of 50 to 60% if there's an implantation of these defibrillators.
I know all this comes with a cost, but it's very reassuring to know that you can still lead a comfortable life. And many people ask this question, okay, now doctors, see the patients, the cardiologist have seen the patient has come back to me and then asked me, doctor, can you do an echo and tell me whether my heart failure is under control or not? And this is a question that all physicians are asked. And what's your answer to that as a cardiologist?
I mean, great question. I think, we look at physician as our partners, diabetologists as partners, because we need to co-manage these patients of diabetes together. We share the responsibility of keeping them out of the hospitals, improving their quality of life. So what we really look at is 2-3 things. One, most important is look at their body weight. They should not gain the body weight. Their blood pressures have to be managed very well, especially in those with heart failure and mild renal dysfunction. Thirdly, periodically look at their effort tolerance to walk the same distance.
Without getting breathless.
Yeah. Are your quality of doing exercise, has it remained same, improved or deteriorating? If it is deteriorating, then I need to test further, do another NT-proBNP.
Yes.
Look at worsening valvular stenosis or worsening coronary artery disease. I need to look at those. And then we are going to look at, are my medications optimized? So I need to go up a little bit on a loop diuretic if they are becoming short of breath. And then if they ask you, can you objectively tell me, has my heart function has improved? That's another question that you would be asked. We always tell them, heart failure management is a functional assessment and keeping you well. So look at your blood pressures, look at your effort tolerance, look at your body weight. That's the best indicator. Your hunger, ability to sleep, that is the best indicator. Objectively from my side, serially looking at the ejection fractions are one good yardstick, and the other one is we put them through exercise tolerance, treadmill test. That will tell us how well they are doing, and it reassures the patient. I can go do a trek, I can travel high altitude. So these things are a good indicator of objectivity.
Excellent. I think you have very comprehensively covered most of the things. What is important is we learned so much about heart failure management in terms of the medications that we are going to use. And Dr. Girish made it very clear it's going to be beta blockers, which will come in as number one. SGLT2 is probably number two in the list. Then you have your diuretics and then ARNI coming in. And most importantly, it's a shared responsibility between the cardiologist and the treating physicians. There is a lot of education to be done. There's a lot of dietary advices that needs to be given. Well, the patient has to be compliant and also has to be patient. Not only the patient has to be patient, but I think the doctors also have to be patient. And you will have a beautiful checklist. I'm sure those of you who would like to actually get in touch with Dr. Girish can actually get in touch. He works at the Apollo in Bangalore. You can actually get a checklist of the things that you can ask your patients to follow so that their life can be sweet and their life can be not breathless despite having diabetes and heart failure. Thank you very much. Have a great day.
Thank you, Dr. Aravind. It was pleasure.
Thank you so very much.
Such a wise man. Thanks for having me on this discussion. To summarize, people with diabetes tend to have higher probability of suffering from heart failure. It's important to suspect, evaluate, diagnose early, and manage them on a continuous basis. I think in that, SGLT2 inhibitors have been one of the greatest invention of the decade, and I'm sure if started in appropriate time and compliance maintained, will keep many patients out of the hospitals. Thank you. Have a wonderful day.
Thank you.
Pleasure, sir.
See you then.